Intestine. Intestinal tumors. Small intestine. We have benign and malignant, benign, epithelial and mesenchymal, epithelial such as adenoma, post-Jigger's polyps, and mesenchymal as lipoma and leiomyoma, malignant in order of frequency, non-Hodgkin lymphoma, adenocarcinoma and carcinoid tumor. For the colorectum, we have benign and malignant, malignant primary, carcinoma, carcinoid tumor, and sarcomas. This is the primary, and we have secondary metastasis. For the benign, we have epithelial and mesenchymal, mesenchymal such as lipoma, leiomyoma, and hemangioma. And for the epithelial, neoplastic hamartoma, juvenile polyps, and post-Jigger's polyps. The neoplastic polyps are divided into solitary or familial polyposis coil with Gardner syndrome. The solitary divided into tubular 5%, tubule vellus 22%, and vellus in 40%. Small intestine tumors are rare. Benign tumors of small intestine may cause bleeding or intussusception. Carcinoid tumor of the small intestine is less common than that of the appendix, but more malignant. Tumors of the colon and rectum share common properties, so referred to as colorectal tumors. Benign colorectal tumors usually form polyps. Post-Jigger's syndrome, multiple familial intestinal hamartomatous polyps, mainly affecting the jejunum. Melanosis of the oral mucosa membrane and lips, not highly precancerous. Only the complicated polyps causing bleeding or intussusception require removal or excision of the affected intestinal segment. Familial polyposis coil, or FPC. Etiology: autosomal dominant disease, affecting 50% of the children of the affected parents. Only individuals with polyps transmit the disease. Males are affected more than females. Pathology: site, sigmoid colon and rectum, commonest sites. They are full of multiple polyps, at least 100. Macroscopic picture, sessile and pedunculated. Microscopic picture, 3 histological types are recognized: tubular, tubulovellus, and vellus. Risk of malignancy: carcinoma develops in 100% of untreated patients by the 5th decade. The malignant potential is related to size and type of adenoma. The incidence is highest with vellus adenomas, which are more than 2 cm. Clinical picture: type of the patient between the age of 10 and 15 years. Symptoms: diarrhea, bleeding, and abdominal pain. Investigations: barium enema showing multiple rounded filling defects throughout the colon and rectum. Sigmoidectomy or colonoscopy and biopsy prove the disease nature. Treatment: it's operative and directed towards eradication of the polyps. Surgical options are similar to those ulcerative colitis, including panproctolectomy, which is a standard treatment, excision of the whole colon and rectum with permanent ileostomy. The rectum may be spared, and ileoproctostomy is performed with endoscopic fulguration of the remaining rectal polyps. Proctocolectomy with distal rectal mucosectomy. The mucosa of the lower part of the rectum is cored out, leaving its muscle wall. An ileal pouch is fashioned to act as a reservoir and anastomose to the anal canal within the remaining rectal muscles. The family members should be periodically examined by colonoscopy and similarly treated if they develop polyps. The avoidance of an ileostomy encourages the asymptomatic person to have the operation. Genetic screening of the relatives is performed nowadays. Gardner syndrome is familial polyposis coil with polyps in the rest of the GIT, osteomas of the mandible and skull, soft tissue tumors, and desmoid tumors of the abdominal wall. Carcinoma of the colon and rectum. Incidence: one of the leading causes of death in Western society. The peak of incidence is in the 7th decade. Etiology and risk factors: chronic irritation, benign lesions, and genetic factors. Chronic irritation, ulcerative colitis. Risk is highest with pancolitis, more than 10 years. Diet: lack of high fiber diet and increased animal fat, as in Western countries. Ureterocolic anastomosis. Benign lesions: solitary vellus adenoma. Genetic factors: most colorectal cancers have established genetic basis. Familial polyposis coil and Gardner syndrome, the risk is 100% in untreated cases, more in large adenomas more than 2 cm, particularly of the vellus variety. The normal epithelium passes through several steps of genetic mutations to develop carcinoma. Multi-step theory: normal mucosa goes for dysplasia, going for adenoma, then carcinoma. Pathology: site, 2/3 of cases in the rectum and sigmoid colon, 10% occur in the cecum. The remainder is distributed over the rest of the colon. Multiple tumors occur in 5% of cases. Macroscopic picture: ulcerative type, cauliflower-like polypoid variety, more in the cecum, and stricture type, more in the sigmoid colon. Microscopic picture: adenocarcinoma arising from columnar epithelium. It may be well, moderately, or poorly differentiated. A colloid structure, some tumors which occur in younger patients and they have bad prognosis. Spread. Direct spread occurring first in the wall, then to the neighboring organs as urinary bladder. The strong fascia of the non-VA lying in front of the rectum delays the spread to the bladder. Lymphatic spread produces deposits in the epicolic, paracolic, intermediate, and then superior or inferior mesenteric para-aortic lymph nodes. Nodal involvement is found in 40% of cases coming to the operation. Bloodstream spread produced liver metastasis in 20% of patients coming to surgery. Transperitoneal spread, peritoneal nodules and ascites. Staging, T and M staging. T1 invading submucosa, T2 invading musculosa, T3 invading subserosa but not reaching the serosa, T4 invades serosa or another organ, N0, no nodes involved, N1, from 1 to 2 nodes involved, and N2, 3 or more nodes involved, metastasis, M0 no metastasis, and M1 metastasis. Complications, intestinal obstruction in 20% of cases, particularly in left colon tumors. This is due to smaller lumen of the left colon. Stool tends to be more solid, and carcinoma tends to be of the stenosing variety. Perforation or formation of enterocolic or vesicocolic fistula. Bleeding. The rule is chronic, not massive bleeding. Complications due to spread as jaundice, liver failure, and ascites. Clinical picture. Type of the patient. Cancer rectum is commoner in males, while cancer cecum is commoner in females. Clinical features depend upon location of the tumor, its size, presence of metastasis. Right colon cancer. Vague presentation with anemia, weakness, loss of weight. The 3 A's, anemia, anorexia, and athenia. Recurrent attacks of pain in the right iliac fossa. Hard colon mass may be present in the right side of the abdomen, is differentiated from appendicular mass by long duration and absence of toxemia and tenderness, doesn't present by intestinal obstruction, as the contents are fluid, the lumen of the colon is wide, and the lesion is usually of the cauliflower variety. Intestinal obstruction occurs in right colon cancer only if the lesion obstructs the ileocecal valve. Left colon cancer. Change of bowel habits, the usual presentation, usually as progressive constipation, but may be diarrhea or attacks of constipation alternating with diarrhea, usually diagnosed and treated as having colitis. Spurious diarrhea early in the morning may be present. Large bowel obstruction may be as acute, subacute, or chronic obstruction. There is constipation, severe distension, but vomiting is late. Sigmoid colon cancer is a very common cause of intestinal obstruction in elderly. Bleeding per rectum, common cause of fresh bleeding per rectum, but not massive. Mass in the left side of the abdomen, rare as the lesions is usually infiltrating sclerosed type. When stools get impacted above the obstruction, it leads to formation of a palpable mass. Massive bleeding per rectum occurs in diverticular disease and angiomatous malformation. Whenever rectal bleeding occurs in a middle-aged or older individual, even in the presence of hemorrhoids, coexisting rectal cancer must be excluded. Rectal cancer, bleeding per rectum, usually slight bleeding, tenesmus, sense of painful incomplete evacuation and passage of mucus, painless, usually unless it has spread outside the rectal wall or infiltrated the anal canal. DRE, palpation of lesions within 10 cm of the anal verge. Higher tumors are revealed by sigmoidoscopy. Investigations for diagnosis: sigmoidoscopy, barium enema, and for patients with acute intestinal obstruction. For sigmoidoscopy, it's essential in all patients with altered bowel habit or rectal bleeding. Mandatory in patients more than 40 years who complain of piles. Biopsy is obtained from suspicious lesions, and biopsy from higher tumor can be obtained by the colonoscopy. Barium enema, the tumor appears as a fixed, irregular filling defect. Annular structures of the left colon show apple core appearance. Exclude second higher tumor even if rectal cancer is palpable. For patients with acute intestinal obstruction, to ensure diagnosis, plain X-ray of the abdomen, blood picture, blood urea, and electrolytes are needed. Barium enema. For staging, transrectal ultrasonography or rectal protocol magnetic resonance imaging (MRI) evaluate the depth of invasion, circumferential resection margin (CRM), and lymph node status, help to determine the need for preoperative chemoradiation therapy. Abdominal ultrasound or CT scan, chest X-ray, and IV urogram if the tumor is expected to be close to the ureter. Preoperative liver function tests, CBC to reveal microcytic hypochromic anemia. For follow-up, carcinoembryonic antigen, CEA, it's non-specific tumor marker, high level in colorectal cancer. It's of prognostic rather than diagnostic value. The level drops after successful radical surgery, and if it shows a rise in the follow-up period, this means recurrence has occurred. Treatment. General principles. Surgery is the main line of treatment. Radical resection is the only curative measure. For inoperable tumors resection, it also offers the best palliation. Treatment depends on whether the tumor presents by acute obstruction or not, and whether the tumor is operable or not. No acute obstruction, operable cases, potentially curable cases, preoperative colon preparation allowing safer anastomosis, should receive elective radical resection. The aim is to cure. This entails removal of the tumor-bearing segment, removal of lymphatic drainage area, and this occurs in one mass, restore bowel continuity. So according to the site, for the cecum, operation is right hemicolectomy, divided vessels, ileocolic and right colic vessels. For ascending colon or hepatic flexure, extended right hemicolectomy, divided vessels are ileocolic, right colic and middle colic. Transverse colon, transverse colectomy, and divided vessels are the middle colic vessels. Left colon, left hemicolectomy, divided vessels are the inferior mesenteric vessels. Sigmoid colon, sigmoid colectomy, and divided vessels are sigmoid vessels at origin from the IMV. Upper third of the rectum, operation, anterior restorative resection. The divided vessels are inferior mesenteric artery, left colic may be spared. Middle and lower third of the rectum, operation is neoadjuvant chemoradiation followed by anterior restorative resection. Divided vessels are inferior mesenteric artery, left colic may be spared. Inoperability can be judged before the operation by the presence of liver metastasis on ultrasound examination. Still, tumors which are preoperatively judged to be operable may prove to be inoperable during the exploration because of liver metastasis, peritoneal nodules, or fixation of the tumor to the important irremovable structures, and this is called irresectable tumor. Colectomy may be done open, laparoscopically, or robotically. Laparoscopic approach is proven oncologically to be equal to open surgery with the benefit of shorter recovery, Lancet on call, and at least 12 nodes are removed to ensure appropriate staging. Must ensure adequate proximal and distal margin, high ligation of the arterial pedicle for lymph node clearance, and tension-free anastomosis with good blood supply to the anastomosis or stoma. Neoadjuvant chemoradiation. It consists of 5-FU, leucovorin with concomitant radiation therapy, XRT, and 54-CGY, currently standard for all patients with T3 or T4 lesions or node-positive disease on imaging with a TRAS or MRI. The goal of rectal surgery to remove the cancer with adequate margins, total mesorectal excision, TME, lymph node clearance with high ligation of the arterial pedicle, consideration of future continence and urogenital function. Tumors of the middle and lower third of the rectum used to be treated by abdominal perineal resection and colostomy. The change towards anterior restorative resection is due to realization that 2 cm safety margin in the rectum below the tumor is compatible with radicality, and so leaving enough distal rectum for anastomosis. The development of the circular staplers markedly facilitated this technique, difficulty procedure. Abdominal perineal excision with terminal left iliac colostomy still is done if there is incontinence, sphincter involvement, improper distal safety margin less than 2 cm, and aggressive pathology, whether undifferentiated, mucinous, or colloid types of cancer of the lower rectum. The following are removed in the right hemicolectomy: terminal 10 inches of the ileum, cecum, ascending colon, hepatic flexure, right half of the transverse colon, peritoneum of the posterior abdominal wall between the colon and the superior mesenteric vessels, containing divided arteries, veins, and lymph vessels with nodes. Operation is followed by doing iliotransverse anastomosis. In extended right hemicolectomy, resection extends to the junction of the right 2/3 and left 1/3 of the transverse colon. In transverse colectomy, transverse colon is resected with both hepatic and splenic flexures, and the transverse mesocolon with the omentum are also removed. Left hemicolectomy, the resection extending down to the rectum. In anterior restorative surgery, the sigmoid colon and upper half of the rectum are excised. Inoperable or incurable cases, whether inoperability is diagnosed before or during surgery, resectable tumor, palliative local resection of the colon cancer without lymphatics and vessels removal, aim to avoid risk of obstruction and bleeding. For irresectable tumor, operation to avoid obstruction. For the right colon, a side-to-side iliotransverse anastomosis. Elsewhere in the colon, proximal colostomy. The rectum show partial response to local radiotherapy. The supplementary chemotherapy with 5-fluorouracil F5U may be useful for colon cancer. Acute intestinal obstruction Urgent surgery is required after adequate preparation. Good general condition. For operable cases, radical resection. Inoperable, palliative local resection, followed by anastomosis. For the right colon, primary anastomosis, and for other parts, colostomy with later anastomosis. Distal obstructed limb is withdrawn with loop, ostomy, or mucus fistula. Critically ill patients, we perform proximal colostomy. Worse prognosis of colorectal cancer occur in younger age at clinical presentation, colonic obstruction or perforation, blood vessels or lymphatic invasion, liver and or distant metastasis, and finally aneuploidy. Intestinal trauma, etiology, blunt abdominal trauma, penetrating trauma, indirect trauma, or iatrogenic injury. Blunt abdominal trauma as in road traffic accidents or blows to the abdomen, presence of seatbelt injuries leads to direct attention to the possibility of intestinal injury. Penetrating trauma as stabs and bullets, high-velocity missiles, are more damaging than low-velocity ones and stabs. Indirect trauma as blast injuries are known to affect the colon. Iatrogenic injury is increasing. Examples include duodenum, colon, and intestine. Duodenum during endoscopic sphincterotomy due to removal of a stone from the common bile duct, colon during colonoscopic diathermy excision of polyps, and intestine during laparoscopic surgery when the pneumoperitoneum needle is introduced in an area where the intestine is adherent to the anterior abdominal wall. Colon injuries are more dangerous than those of small intestine because of the magnitude of infra-abdominal contamination. Types of injury: contusion and hematoma, rupture, complete or incomplete, single and multiple, tears of mesentery or mesenteric vessels leading to hematomas and gangrene. The sequelae of the intestinal trauma: peritonitis due to escape of intestinal contents, internal hemorrhage, less important than peritonitis, hypovolemia and septic shock, paralytic ileus, intestinal obstruction due to healing of the injuries by strictures and massive adhesions. Clinical picture: symptoms, history of trauma, abdominal pain starting at the site of injury which then spreads, signs, general and local, general tachycardia, fever, and hypotension, local signs, by inspection, signs of injury in the abdominal wall as bruises or inlet and exit wounds of missiles, distension due to developing ileus, palpation, tenderness and rebound tenderness, percussion, lost liver dullness due to free air in the peritoneum, and shifting dullness due to free intraperitoneal fluid. Investigations: laboratory tests such as leukocytosis and hemodilution. Radiology: plain X-ray of the abdomen may show free air under diaphragm, multiple fluid levels due to ileus, bullets and sharpnels and fractures. Ultrasound or CT scan may reveal hematoma or intraperitoneal collection. Diagnostic peritoneal lavage may show free blood, bile, or intestinal contents. The frank picture of peritonitis may be delayed in patients with tiny perforation. Sometimes the injured segment is contused and it takes some time to perforate. Whenever in doubt, it's better to keep the patient under observation of the hospital for 24 hours. The diagnosis of bowel injury is mainly clinical. Investigations done only in doubtful cases. All intestinal injuries require laparotomy. Treatment: priorities of multiple trauma management should be followed. Preoperative preparation, anti-shock measures, antibiotics which cover gram-negative bacilli and anaerobes, combination of third-generation cephalosporins and metronidazole, tetanus toxoid boosting dose, insertion of nasogastric tube and self-retaining urethral catheter. Operation: abdominal exploration equals laparotomy, midline abdominal incision, full abdominal exploration for solid and hollow organs. Bleeding should be urgently stopped. Leaking intestine is dealt with according to the site. Small intestine and right colon injuries according to the type. Tidy sharp injuries sutured in 2 layers. Ragged injuries, trimming of the edges and suturing. Ischemic or gangrenous segments due to mesenteric vessels injury, extensively contused segments, and for multiple closters, intestinal resection and restoration of the intestinal continuity by primary anastomosis. The peritoneal cavity is irrigated with copious amounts of saline before abdominal closure. Transverse and left colon injuries according to the type. Localized injuries which can be exteriorized. The injured part is brought out of the skin through opening in the interior abdominal wall to act as colostomy, and if the injured part cannot be exteriorized, the tear is sutured and protected by proximal colostomy to divert the feces away. Colostomy is electively closed after 3 weeks with adequate colon preparation. In cases where resection of the segment is done, proximal end is brought out as terminal colostomy. the distal end is either brought out as mucous fistula, and this is called Mikulic's method, or closed as Hartmann's procedure. Elective anastomosis done after 3 weeks. Intestinal fistulae. Definition: abnormal communication between two epithelialized surfaces and usually formed by granulation tissue which may be sometimes be lined by epithelium. Etiology: congenital, patent vitello-intestinal duct which discharges at the umbilicus. Acquired trauma after abdominal operation in 80% of cases due to unrecognized intestinal injury or failure of an intestinal anastomosis caused by anastomosis under tension, anastomosis in presence of sepsis, distal obstruction, poor vascularity, lack of proper surgical technique, presence of specific pathology as Crohn's disease, generalized diseases which impair healing as hypoproteinemia, abdominal trauma as in road traffic accidents, inflammation as colonic diverticulitis, Crohn's disease, radiation enteritis, and finally tumors. Classification: according to the site of the opening, we have internal fistula and external fistula. Internal fistula connects intestine to hollow viscera in the GIT or urinary tract or vagina. External fistula connecting intestine to the skin, and they are further classified into low output fistulae which discharge less than 500 milliliters per day and high output fistulae discharging more than 500 milliliters per day. Then, according to the origin in intestine, known by nature of the discharge, we have bile-stained fluid fecal discharge and semi-solid fecal discharge. Bile-stained discharge from duodenum or jejunum, fluid fecal discharge from ileum or cecum, semi-solid fecal discharge from distal colon. Complications: metabolic effects include dehydration, malnutrition as hypoalbuminemia, electrolyte disturbances, hyponatremia, hypokalemia, acid-base disturbance, acidosis, common with high output fistulae, and they are the results of malabsorption and loss of intestinal content, sepsis leading to severe catabolism, aggravating malnutrition. Sepsis: this is a major problem if the fistula tract is not effectively walled off, enteric contents escape, and intraperitoneal abscess occurs. Skin irritation and maceration due to continuous flow of intestinal contents. Investigations: the aim is to detect level of the fistula, presence of bowel disease, presence of distal obstruction, and presence of intraperitoneal sepsis. The means of diagnosis are clinical assessment, barium meal follow-through, fistulography, and ultrasound or CT abdomen to detect abscess cavities. Managing an intestinal fistula proceeds in the steps: resuscitation and skin protection, then skin protection alone, nutritional support, and definitive treatment. Resuscitation and skin protection: IV fluids to restore normal blood volume, fluid and electrolyte balance, blood transfusion may be needed. Skin protection: start as early as possible as the fistula is recognized. If excoriation occurs, it leads to difficult management. An adhesive cover and disposable collection bag are applied to the skin around the fistula. The skin is protected and the effluent can be measured. Nutritional support with high output or proximal fistulae, parenteral nutrition. With low output and distal fistulae, enteral nutrition. Definitive treatment: for external fistula, if the output is decreasing, continue conservative treatment. Surgical intervention indicated for distal obstruction, cases showing no improvement over 4 to 6 weeks, active disease at the fistula site such as Crohn's or malignancy, total discontinuity of bowel ends, and mucocutaneous continuity. Internal fistula, spontaneous closure is rare and may not require correction. Surgery is indicated for fistula which bypasses long segment of intestine leading to malabsorption, internal fistulae to the urinary tract. The amount of fistula output has been important bearing in its metabolic effects. Abscess should be drained either surgically or aspirated under sonographic or CT guidance. The majority of intestinal fistulae heal spontaneously if sepsis is eradicated, nutritional status is maintained, distal obstruction is relieved if present, surgery in the form of resection of the affected segment and anastomosis of healthy ends is performed. A good nutritional status allows resection of the diseased bowel segment and anastomosis in one stage. Mucous diverticulum. Etiology: caused by persistent patency of proximal part of vitello-intestinal duct of the embryo or omphalomesenteric duct of the embryo. The abnormal persistence of the duct may produce other anomalies as well. Persistent patency of the whole duct leading to fecal fistula connecting the ileum with the umbilicus. Persistent patency of the middle part of the duct leading to enterocyst. Persistent umbilical extremity of the duct everted producing an umbilical polyp, and fibrous band remaining after obliteration of the duct. Definition of intestinal diverticula: it's a blind pouch which is continuous with the lumen of a hollow viscous, gut or urinary bladder site, occurring anywhere in the bowel from duodenum to sigmoid colon. The commonest are Meckel's diverticulum and diverticula of the colon. Pathology: it's a true diverticulum consisting of all layers of the bowel wall site lying on the antimesenteric border, separate blood supply by a branch from the superior mesenteric artery. It may contain ectopic, gastric or pancreatic or colonic cells. Rule 2 of 3 as an approximation. Occurs in 2 to 3% of the population, situated in the ileum 2 to 3 feet from the cecum, 2 to 3 inches in length. Complications occur in about 2 to 3% of the affected patients, male to female ratio 2 to 1 and 2 to 3 cm in diameter. A Meckel's diverticulum is the most prevalent congenital anomaly of the GIT. Clinically, it's impossible to differentiate it from appendicitis, so it's usually explored on the provisional diagnosis of acute appendicitis. If appendix found normal at operation, look for a Meckel's diverticulum. Clinical picture may be accidentally discovered at operation for another pathology, may present by clinical picture of its complication as intestinal obstruction, painless rectal bleeding in childhood, acute abdominal pain simulating appendicitis. Complications: intestinal obstruction, peptic ulceration and bleeding, acute diverticulitis, and Letter's hernia. Letter's hernia become content of an inguinal or a femoral hernia. Acute diverticulitis, similar to acute appendicitis, gangrene and perforation may occur leading to peritonitis. Peptic ulceration and bleeding, particularly in childhood, caused by ectopic gastric mucosa. The ulceration occurs in the intestinal mucosa adjacent to the base of the diverticulum. Intestinal obstruction: this is the commonest complication, may be due to intussusception or fibrous band. Intussusception: the ectopic mucosa at the base of the diverticulum act as a foreign body and forming the apex of ilio-ileal intussusception. Fibrous band, which attach diverticulum to the umbilicus, leading to pressure on an intestinal loop and allow rotation of the ileum around its axis, leading to volvulus. Bleeding secondary to Meckel's diverticulum is the commonest cause of lower GIT bleeding in children. Investigations: for umbilical sinus or fistula, cannulation and contrast injection by umbilical tract. Upper and lower contrast studies rarely outline the primary defect. Technetium TC99M may localize in gastric mucosa lining Meckel's diverticulum and may identify the source of hematochezia or melena. Retention of dye in the mucus and parietal cells enhanced by giving cimetidine 30 mg per kilo IV 30 minutes before administration of the radiotracer nuclide. Treatment: symptomatic cases and accidentally discovered cases. Symptomatic cases, resection is indicated. For accidentally discovered cases at laparotomy, in children and young adults, in those with an attached band, resection is indicated. In other instances, particularly in patients more than 40 years, leave it, as risks of resection outweigh the advantages. Diverticular disease of the colon. Etiology: lack of fiber in diet, leading to chronic constipation and increased intraluminal colonic pressure. Increased muscle spasm and segmentation play also a role. Pathology: nature represents pulsion diverticula of the colonic mucosa. Site: any area of the colon may be involved. The sigmoid colon is the commonest site affected. The rectum is never affected. Development: early stages. There is only muscular spasm and incoordination. Next, the mucosa starts to bulge outwards through circular muscular layer at points of entry of blood vessels between the tinea and at the antimesenteric border. This is called diverticulosis or non-complicated diverticular disease. Complications: acute diverticulitis, inflammation of one or more of the diverticula secondary to obstruction of its neck, perforation, lead to localized or generalized peritonitis, may be a sequel of acute diverticulitis, recurrent attacks of acute inflammation, bleeding, condensed feces, leads to erosion of blood vessel at the neck of the diverticulum, colon structure, leading to large bowel obstruction, secondary to chronic diverticulitis, fistula formation, colovesical, colovaginal, or colointestinal fistula. Clinical picture: type of the patient, uncommon before the age of 40, incidence increases with age. Non-complicated cases: either the patient may be asymptomatic or complains of recurrent attacks of lower abdominal pain, distension, and flatulence. Complicated cases: acute diverticulitis mimics clinical picture of appendicitis but on the left side. Symptoms: abdominal pain. Signs: pyrexia with tenderness and guarding in left iliac fossa. Complications: pericolic abscess or generalized peritonitis. Chronic diverticulitis, long history of recurrent attacks of pain with passage of blood and mucus per rectum. On palpation, there is a tender mass in the left iliac region. Fresh bleeding per rectum may be the first presentation of the disease. Profuse hemorrhage. Diagnosis of the source of bleeding is important and will be difficult by colonoscopy, so we perform angiography, which is the most useful. Investigations, radiological and instrumental. Radiological, barium enema. In the pre-diverticular stage, we have sawtooth appearance. Later, fully developed diverticula are visualized and can diagnose concomitant lesion. CT scan, the best investigation in acute diverticulitis. It reveals thickening of the colonic wall and peridiverticular abscess or extraluminal gas. Angiography, the most useful in bleeding per rectum. Instrumental, sigmoidoscopy, will detect the mouth of diverticula and its more value to diagnose any concomitant lesion. Before treatment, the mass of chronic diverticulitis has to be differentiated from carcinoma because in carcinoma there is a history of short duration and pain is absent in 25% of cases. Treatment: for uncomplicated cases or diverticulosis, high fiber diet is prescribed, antispasmodics for abdominal colics. In complicated cases, acute diverticulitis, conservative treatment same as appendicular mass. Usually the inflammation settles on conservative treatment. If complicated by pericolic abscess, open drainage or ultrasound-guided percutaneous aspiration is performed. Generalized peritonitis, urgent laparotomy, resect the perforated colon by Hartmann's and do peritoneal toilet and drainage. This is the best method. Exteriorization of the perforated segment or suture of the perforation with a defunctioning colostomy is less successful. Chronic diverticulitis, colectomy is performed after adequate preparation of the colon. Bleeding, adequate resuscitation. In majority of patients, the bleeding stops spontaneously. If the bleeding is massive or persistent, do angiography to localize the site of bleeding and urgent colectomy is performed. In acute diverticulitis, barium enema is contraindicated. Instead, use CT scan. Commonest causes of massive bleeding per rectum: diverticular disease of colon, angiodysplasia of the colon. Cancer colon is a commoner cause of bleeding per rectum, but it's not massive bleeding. And this concludes our part for the intestine for today.